Hello, I'm Patricia McCrystal, a psychologist working within the field of health psychology, and my small step change project was set within the Psychology Pain Management Service in Craigavon Hospital, a service that was established to help people develop a greater quality of life despite their chronic pain. Patients present with chronic pain due to a range of diagnoses such as pain following an injury, osteoporosis, fibromyalgia, surgery, cancer and arthritis. To inform you further, patients are referred to a pain consultant by their GP. The pain consultant determines the best medical treatment options such as medication, injections, surgery and the like. When all options have been tried or considered or are inappropriate and the patient remains in chronic pain, they are referred to our service and invited to attend for psychological assessment. If the patient accepts an assessment appointment, a chart is made up by the administrative staff. The patient is then assessed by a psychologist and the focus is on their coping strategies. And then they are offered a place in the pain management programme or the fibromyalgia group. Following completion, they are reviewed again and discharged from our service. So this is our project team. First person here is Nicola, our personal secretary, and then myself, Patricia McCrystal, psychologist. And we've been investing much of our time and energy in ensuring that this project achieves its goals. So why carry out this project? In the last 3 years, our major focus has been on managing the increasing waiting list with the added complication of staff change and reduction affecting both admin and clinical staff. Consequently, audit preparation has been in the background. It was noted that a number of versions of documents and patient charts existed, and on occasions some documents were not available for use in new patient charts. Both of these issues had an impact on clinical procedure, mainly with regards to sourcing the documents and completing relevant sections in a timely manner at the patient's first assessment appointment. This frustrated clinical and administrative staff, and it has been persistently evident that all of the staff in our department are committed to best practice and offering a patient-centred service. However, time is limited for making amends to rectify the situation, and so the situation continued. So using the 5-step model, we commenced our preparation by preparing a small step change project initiation document, which helped us clarify the issues and our vision of having consistency in patient charts in terms of documents used and the completion of documents. To help us get some baseline measures, we took a random sample of 20 new patient charts in June 16 and analysed these mainly in terms of inclusion or exclusion of documents, whether it was the latest version of documents and the completion of these documents. I then recorded my time in amending each of these 20 new patient charts and identified an average time. And having achieved this data, we then devised an action plan and subsequent communication plan to make the necessary quality improvements. Staff engagement was essential, as it was difficult to get the team to meet due to mostly annual leave and maternity leave. A few of us met in my office to commence an Ideas and Frustrations board. The Ideas and Frustrations board was then left in the Secretary's office in the Bluestone unit so that more members of staff had the potential to participate. I emailed and spoke with various staff to encourage feedback. Based on the qualitative feedback received from this Ideas and Frustration board, a fishbone diagram was produced and summarised in this slide. Firstly, good but non-standardised record procedures were utilised by administrative and clinical staff, and this persisted due to little internal auditing. Historical issues, formerly one-person service with excessive waiting lists, staff growth immediately followed by staff reduction, recruitment issues beyond our control and significant time pressures. Thirdly, there was a variation in documents used. A number of versions existed, and whilst all were suitable in different ways, it meant that clinical staff had to hunt through up to 10 pages of a document to find the correct section to record information when assessing a new patient. And finally, it was evident that all admin and clinical staff invested their energies in ensuring that patients were cared for in the best manner. Patients were at the centre of our service. So here's how we did what we did. We sorted the feedback from the ideas and frustration board into two categories. Firstly, the actual documents included in patient charts, and secondly, the completion of documents. And we set to work on how best to improve quality in these two categories. So we divided our implementation into two parts. We took the actual new patient charts and assessed them for content, reviewed and agreed all documents, and made amendments to standardise them for future use. These new versions were dated in preparation for any internal or external audit. For part 2 of the implementation phase, we looked at trust guidelines for writing a standard operating procedure, and using a PDSS cycle, we prepared our first draft for review, amendment and agreement. To aid us, we looked at guidance from the British Psychological Society and guidance followed by our physiotherapy colleagues and additional trust guidelines. So having carried out a risk analysis at the outset of this project, the main risks regarding time pressure and staff shortage became eerily true. Not only did we have these issues at the outset, but they increased in intensity during the lifespan of this small step change project, mainly due to additional annual leave and maternity leave. My sense of responsibility was heightened to ensure momentum, and the person-centred approach to patient care was emphasised as more time was invested in ensuring this due to increased staff shortage. For us, the way forward is very clear, and that is to persist with the good work that has been completed already in this project and to see it through to completion. The standard operating procedure will be signed off and implemented by all staff and will be reviewed again in 2 years. New staff will be given this standard operating procedure as part of their induction. New patient charts will be standardised, allowing time for various versions of documents to run out and the new standardised versions to be utilised. An annual internal audit will then be scheduled, and feedback was and will remain critical, and all will be encouraged to provide and receive feedback. So thank you for taking the time to view my vodcast. Again, I'm Patricia McCrystal, and please feel free to contact me on my email address below.